Session 6 describes frameworks used in defining primary care, and it turns out that there are many different ways to think about what primary care actually means to different stakeholders. We introduce the business model perspective, the provider's identity within the space, as well as the view of the academics.
One of the biggest questions that nobody is answering is what exactly is primary care? And it seems that many people in the health tech world, the regulatory world, and even among doctors have their own definitions of primary care. And in this module, we're going to try to define it a little better and try to get everybody on the same page or at least thinking in a similar way. We're going to explore the different ways to look at primary care and the different components of it. The first one is business models. One of the most influential books for both Paulius and I has been The Innovator's Prescription by Clayton Christensen. In his book, he actually talks about this in a hospital setting. They have different business models all under one roof. And the same thing happens in primary care. The three business models are the solution shop, which is where experts come together to solve an unstructured problem that requires some time and energy and creativity. The value added process, where there is a simple A to Z, for example, ingredients going through a recipe becoming a meal, and then facilitated networks, where generally forums and communities work best to solve a problem. In primary care, the solution shop would be the undifferentiated patient, the patient who comes with new onset abdominal pain, vision changes, headaches, things that require some sort of workup and maybe a treatment, not so much as a treatment, but as a way to test a theory. The value added process would be like strep throat. You come in, your throat hurts, you run some tests, it's strep or it's not, or a flu test. Flu COVID nowadays. You run the test, you either have the flu or you don't, and there's pretty defined treatment plans for if you do or do not. Facilitated networks in primary care would be the chronic diseases, diabetes, hypertension. So any sort of support group, forum, Facebook group, Reddit subreddit, perhaps that could be overseen by a nutritionist or a doctor or a nurse or something is what that would or should look like. The other way to look at it is who does primary care, the specialties that go into it. Most commonly associated with primary care is family medicine. We talked in Module 1 a little bit about the family medicine training, which is predominantly in the outpatient setting, but spans all the care settings as well as multiple specialties. One of the reasons family medicine actually started back in the 60s was as a way to bring medicine out from the academic medical centers in major cities and into communities. Family medicine residencies were some of the first and potentially still the only ones that have, quote, community practices where the office is within a neighborhood rather than centralized in a large academic tower. Pediatrics is another common one. And then internal medicine. The main difference between internal medicine and family medicine is internal medicine only does adult medicine, so no kids and no pregnant women, and most of their training is in the hospital. The other big difference is internal medicine is like doing medical school a second time. It's 3 years, and 80 to 90% of internal medicines will then go on to do a fellowship and specialize. Stomach doctors, heart doctors, lung doctors, all of them have to go through an internal medicine residency first before they specialize into whatever organ system they're specializing into. And because internal medicine has such a strong focus in the hospital, most people that I know who do IM residencies, the programs that they go to have pretty dysfunctional primary care clinics, which disincentivizes or makes them disillusioned towards primary care, which probably to some degree drives the large number of people who end up specializing. These three are the core primary care providers. And then you have some specialties that probably never intended to or sometimes don't even want to be primary care, but they just happen to be because that's where a lot of people go for their initial contact and even develop some continuity. OBGYN for women who are getting their mammograms, their routine PAPs. Sometimes OBGYN will start managing other chronic conditions, and the women don't know where else to go besides for their OBGYN. Psych with all the mental health, a lot of times people start there with their mental health issues, and then that becomes somehow their primary care. Though I do want to note that psychiatry residencies have very little medicine in their training. So, to what degree psychiatrists practice internal medicine and chronic care, like diabetes and hypertension, is pretty varied and probably limited. They probably will at some point refer out to other specialists. The ER, we talked about how the ER is actually a setting for primary care because people can't get into primary care or other people won't accept them. And the ER docs end up doing a lot of chronic med refills and then they burn out and open or join primary care offices. And then a few other specialties, endocrine and cardiology being the two most common ones. So if someone only has diabetes and complications from diabetes, endocrine may become their primary care. And likewise, people with heart issues and only heart issues, cardiology ends up becoming their primary care, as cardiology also does blood pressure and some metabolic disease and lipidology. And then, of course, there are the non doctors, which growing rapidly is the independence movement for nurse practitioners. So, nurse practitioners to varying degrees can practice independently in their own clinics, depending on state. And less so, but growing now, also physician assistants, which have rebranded themselves to physician associates, are trying to open their own practice. And in the states where either NPs or PAs cannot practice independently, they'll frequently have some sort of mercenary doctor, or as they call it, quote, consulting physician, who sits on the side, collects a check from them every month, and signs off on all their notes. Pharmacists is another interesting group that somehow have become some degree of primary care because they, in several states, Virginia did not successfully pass the bill, but in some states, they're trying to have pharmacists run some of the value-added process illnesses. So they want to do strep tests and flu tests and COVID tests at the point of pharmacy. So instead of going to the minute clinic at Kroger, you walk up directly to the pharmacist, ask for a swab, they swab you, and then they wanted to attach some prescribing abilities to the pharmacist as well. Again, this is all a scope of care fight. So, depending on what gets passed in the future, it's not unreasonable to see some people going to directly to the pharmacy as their primary care. And then the larger, more esoteric, but equally as important framework for primary care is an academic one, which we'll dive into deeply. A complete primary care offering should have the four C's. They are the point of first contact, comprehensive care, care coordination, and continuity. And we'll zoom into each one of these in the next four sessions.
To summarize, we learned about all the different takes on what primary care actually means to business people, to clinicians, and to academics. This concludes session 6.